Okay, so the first thing that I want to talk about when it comes to the diabetic drugs is the difference between hyperglycemia and hypoglycemia. So normal blood sugar is usually like 70 to 110, 120. That's a typical normal blood sugar level. But hypoglycemia is when we have a sugar less than like 40, and hyperglycemia is pretty much anything over like 120, 130s, 140s, 150s. So the reason I put an emphasis on the difference between the two is because you might get a question that talks about the signs and symptoms, or they might give you the signs and symptoms and it might not necessarily say they're in a hyperglycemic or a hypoglycemic crisis. So it's good to know the signs and symptoms so you have an understanding of what's going on. So, in terms of hyperglycemia or high blood sugar, we get things like fatigue, they become lethargic or confused. Um, we also get irritation, glycosuria, or sugar in the urine, polyphagia, polydipsia, which polyphagia means increased hunger and polydipsia means increased thirst. Now, that those three P's, polyuria, polyphagia, and polydipsia, are characteristic for diabetes. It is something that you expect for them to have, especially when their sugar levels are really high. And something that you can get when your sugar becomes really high, and I mean a blood sugar of like, let's just say 300, you can go into something called DKA, which is diabetic ketoacidosis, which is fruity breath, dehydration, and something called Kussmaul respirations, plus the normal characteristics that we see in diabetes mellitus, like the three Ps. You could also get something HHS, which is like hyperosmotic something syndrome, which is another form of really, really high blood sugar. But DKA we see in type 1 diabetes, and the other one you see characteristic in type 2 diabetes. This becomes really important in understanding that when we start talking about the medications. Now, something else that patients may have who are diabetics is they might also go into something like a hypoglycemic crisis where their sugar drops way too low, like I said, around 40. So they'll get shaky, they'll have a really fast heart rate, they'll be sweaty or diaphoretic, they'll have hunger and blurry vision. And this is why we keep emphasizing that we have to watch out for those beta blockers with our diabetic patients because they mask symptoms of hypoglycemia. And a mnemonic that might be good is like tired because that means like tachycardia or tremors, insomnia, restlessness, excessive hunger and things like that. It means the symptoms that you're seeing here, but if you need like a little mnemonic, tired might be good, and the D can stand for dizziness. So it is a good little way to memorize it if it's hard to memorize the symptoms, but I think it's good to know the difference between the two because they might say your patient is coming in and they're shaking, they're tachycardic, they're diaphoretic, and they have a history of being insulin dependent. Now, your mind should start saying, okay, they might be going into a hypoglycemic crisis and I need to check their blood sugar. So, just something like little things like that could really help you on your exam questions. Now, like I said, the three Ps are very common characteristics of diabetes mellitus. And like I said, diabetes has to deal with this problem with the sugar because there's a problem with insulin. Either they're not making enough insulin, they don't have any insulin, or they have insulin resistance. So type 1 diabetes is when we have pretty much little to no insulin. Whereas type 2 diabetes is more or less in resistance to insulin. So they have it and they are just not able to use it properly. And that's due to lifestyle issues and diet issues that they are not taking care of themselves the way that they should be. So, something else that I really, really want to emphasize is that something they could ask you also about when it comes to diabetic drugs is like, how does a diabetic patient, or how do we know that they are taking these medications the way they're supposed to when they're managing their diabetes? Well, they do something every 3 months called a hemoglobin A1C level, and we want that to be under 7%. Under 7 or under 6 is wow, they're really controlling their sugar levels and there's not an excessive amount of sugar in the blood. Greater than 7, they are not controlling their diabetes. And that's something really, really important to know because it does relate to pharmacology and it can be on your exam. Now, potential problems that you can get with diabetes include problems with your vision, a retinopathy, nephropathy, or problems with the kidneys. We could have cardiovascular problems, foot ulcers, and even erectile dysfunctions. Now, something that I really want to emphasize, the reason I'm going into the differences of the different diabetes, because certain medications are only given for certain types of diabetes. So, gestational diabetes and type 1 diabetes mellitus only take insulin. They're not going to take those oral anti-diabetic agents. They're not going to take any of that. They only take insulin. So, type 1 diabetics, they can only have insulin. Gestational diabetes or diabetes that occurs as a result of being pregnant. So, they get this usually during 20 weeks of being pregnant. They are having uncontrolled sugar levels. They must use insulin because insulin doesn't cross the placenta and it doesn't get to the baby, which is really good. So we can give insulin during pregnancy. So if they get gestational diabetes or type 1, they must take insulin. There's no way around it. They're not getting anything else. Type 2 diabetes, every other drug besides like insulin is pretty much just for type 2 diabetes. So all of those oral anti-diabetic agents that we're going to be getting into are using or are forgiven for type 2 diabetes. So that's something I want you to know because even if it's becoming hard to memorize everything, if you know insulin's only for a specific group or type of patient, then you know, okay, I can only give this in this situation. So, like I said, those are the differences between the types of diabetes, and what we give in situations if they're in type 1 or gestational or type 2. So now let's get into insulin. So we can give insulin as a result of it's like a synthetic hormone. So insulin is a synthetic hormone that we can give in order to help replace insulin. See, the thing is, like I said, with those diabetic patients and with those gestational diabetic patients, insulin is the only thing that we can give, right? Because it doesn't cross the placenta. And for type 1 diabetes patients, they do not make insulin. So that means if they're not making any sort of insulin, they need insulin, okay? So we give this subcutaneously at a 45-degree angle in the abdomen or the back of the arm, lower abdomen, the thigh, like the top of the thigh, or even like the buttocks, okay? And we have 4 different types of insulin, which is very, very important and will definitely be asked on your pharmacology exam. So you have rapid acting insulin, which is Lispro, Aspart, and Glucine. This means they work really, really quickly, okay? So as I said, with insulin, we're giving this to our gestational diabetes or our type 1 diabetics. If we're giving them rapid acting, like Lispro, Aspart, or Glucine, it works so quick, like 15 minutes, okay? If it works that quickly, they need to have food ready when that medication is given. They must have food present. Do not give them this insulin if they do not have food present because the blood sugar can drop so low that they might go into a hypoglycemic crisis. So with our Lispro, Aspart, and Glucine, they must have food present. Short-acting or regular insulin is the only insulin that can be given via IV. We should have food present. Is it a necessity? No, but there should be food present because it works very quickly. And as we know, IV medications work very fast. So we do want some sort of supplemental sugar there. And sometimes if they're given regular insulin, they might be also given like, dextrose, which has sugar in it, which is an isotonic solution like D5W. But we give regular insulin which is IV form, in situations like I mentioned, DKA or HHS, where their sugar is really abnormally high, because that IV insulin is going to work very well in lowering the sugar levels, okay? Then we have intermediate insulin, which takes longer to work, and we call this NPH. Now, with NPH, you can mix it with other insulins. You usually mix it with regular insulin, but you must know this. You must you must remove the regular insulin first. You must draw that one up first and then draw up the NPH. That's because NPH is cloudy. So it wouldn't make sense to draw up the cloudy insulin first and then put it into the clear one like regular. So you want to draw the regular up first and then the cloudy, or the NPH. That's something very important. I could definitely see that being asked on your exams. The next thing that I want to talk about is long-acting insulin. This is like glargine or detamir. So these two are only given once a day because they last so long. They have no peak, so it's not going to get better in an hour or worse. They stay pretty steady for 24 hours, and then you give it again the next day, same time. They last for 24 hours. So the thing with this is that it has no peak. You give it once a day, and you do not mix this insulin with other insulins. You just do not do this. That's a rule of thumb with these long actings. So those are the major differences between all of the insulins, and some of the things that I think you will be tested on, or the things that I've been tested on in the past. That's why I'm emphasizing them. And this is just going into more or less how quickly it works. So, like I said, it takes so quick, like 15 minutes for these rapid actings like Lispro, Aspart, that it must be given with food. The next thing is that regular insulin, or that IV insulin, takes about 30 to 60 minutes, and it's the only one that's given via IV. And normally we give this during like DKA or HHS. Intermediate NPH, it's cloudy, it has a slower onset, so you always draw up the clear regular insulin first, and this one can last almost 24 hours. And this one, long acting like glargine, has no peak, it's once a day, and you don't mix it with other insulins. And it lasts about 24 to 36 hours. And usually you give it once a day at bedtime, which would make sense, right? Because if it's insulin, there's always that potential where sugar can drop a little low, and it may be better that they're sleeping and their body's functioning with this than maybe it happening during the day. Some sick day rules with insulin is that you never stop insulin even if they're sick, because when you're sick or when your body undergoes any form of stress, your sugar levels are going to rise. So if you're sick and you're diabetic, your sugar is going to rise even more. So you need to take the insulin. You can't stop it because you're sick. And because a person's sick, you want to monitor the blood sugar levels more frequently, because they have a higher risk of becoming even more abnormally high because they're sick. And we also want to check out for ketones. Why? Because in diabetic ketoacidosis, a potential symptom is ketones in the urine. So you could think keto, like diabetic ketoacidosis, they can have ketones in that. So they can have some ketones in urine. And know when to call for help, right? If this person's having signs and symptoms of hyperglycemia, and they are having a blood sugar of like 400, and the insulin that maybe they're taking is not working, we really need to call for help. Is there any questions? No? Okay. So as I said, insulin is always given for sure with those pregnant women who get gestational diabetes or type 1 diabetes, and sometimes it's given for type 2, but it has to be given for type 1 and gestational, especially those type 1 diabetics. They don't make any insulin on their own, which means that they need insulin more than anyone else. So they must take it every single day. So things that you have to watch out for with like insulin is if it's not really working, or the sugar gets for some reason abnormally high, they can go have hyperglycemia or go into DKA or even HHS, okay? So it doesn't cross the placenta, which is really great. The most important things besides, like I said, going over the rapid, short-acting this and that, is those beta blockers mask hypoglycemia. I know I've emphasized this in the past, but remember, beta blockers also work on those beta 2 receptors. And besides those beta 2 receptors working in the lungs, they also affect sugar production. So beta blockers can actually mask signs and symptoms of hypoglycemia, which is very scary, especially when someone's taking insulin or they're a diabetic. Also, another really, really important point, which I can definitely see on your exams, is that corticosteroids like prednisone, let's just say we're talking about an asthmatic patient who also has diabetes, steroids are not good because steroids antagonize insulin, or in other words, they raise the sugar levels while insulin is trying to lower them. So when they're on steroids, their sugar levels can be even higher. So we don't really like steroids in conjunction with someone taking insulin. Something else that I would remember in terms of herbs are juniper berries and ginseng. Those are very popular herbs that can also interact with insulin and make sugar levels abnormal. So I would remember those two. If you are going to remember any herbs, I would remember those. And this is just some nursing considerations. Like I said, pregnancy, good for them, right? Allergies wouldn't be so good with insulin. If they have asthma or COPD and they're taking steroids, we might have to be careful with the insulin because the steroids are going to raise the sugar even more while the insulin's trying to lower it. We also want to look at, things like their blood pressure and all of that. Why? Because if they're also taking beta blockers and things like that, their blood pressure can be affected. Respirations, because if their sugar gets so high, they can go into something like I said before, DKA, which causes something called Kussmaul respirations, which are like really, really slowed. And like I said, more of this is just the idea of like looking at everything that we spoke about and thinking about, right, monitoring their sugar levels, looking at their lab values, making sure that the insulin's doing what they're doing, looking at that hemoglobin A1C over the span of every 3 months to see if they're really taking and controlling their diabetes. Now, the thing about the sliding scale insulin, which is normally something you see in the hospitals, is when, let's just say, like you are taking their blood sugar in the hospital and their blood sugar is 130. The sliding scale might say to give them 2 or 3 units of insulin. So that is just a way for like providers to let you know how much insulin to give based on the amount of sugar or their blood sugar level that you get when you test it. So that's all that this really says. That's what the sliding scale means. It's just how many units, because remember, insulin is given in units, not milliliters, units, which is a very special syringe. Based on their sugar levels, we give a certain amount of units. Now, as I said, insulin is only for those type 1 diabetes and gestational diabetes specifically, they can only use those. Type 2 may use insulin. It's not as common, but they may. But all of the oral agents that we are going to talk about are going to be for type 2 diabetes only. This is because they don't have a problem with insulin in terms of not having insulin. Their problem is lifestyle modifications and potentially being overweight or obese that is causing them to make their pancreas affect those beta cells, because it's the beta cells that secrete insulin. Those insulin levels are not really able to do what they need to do because those beta cells aren't working properly because of their lifestyle habits, okay? So we have a few different classes of medications, and it might get a little confusing. So it's great that if you're starting early, because there's a lot of G or G starts and G endings when it comes to looking at these different oral agents. So the first group of oral agents is what we call insulin secretagogue. I don't know how to say that, but let's just call it secretagons. They increase insulin secretion, right? Secretagons, they increase insulin secretion. Now, these include sulfonylureas, that is a class of medications. This includes meglinotides, which are also called glinides, and incretin mimetics, which incretin mimetics are like similar to insulin. They worked very similarly, but they're not insulin. They're like a hormone. And you must take those immediately before eating, because you want to take that so that it can really affect those postprandial or after you eat sugar levels. So you take the insulin and then you eat. With a lot of these medications, you're going to see, because as I said, there's always the issue or the worry that the sugar level might drop too low depending on these medications. And most of them cause as an adverse effect hypoglycemia, but some won't. And those are the ones that I really want you to pay attention for. And there's only going to be two classes of medications that you must take food with the insulin, not the insulin, but the oral diabetic agents, like the insulin sensitizer, binguinide, or metformin. That one must be taken with food. So you take metformin and food at the same time. Whereas all the other medications, you take the medication first and then you take the food like 30 minutes later. Same thing with these, I don't know how to say it, but alpha glucosidase inhibitors, also called Archibos. They're another type of oral anti-diabetic agent that you must take with food while you're taking this medication. Not 30 minutes after, but with. So, as I said, going back to the different types, we have insulin secretagons, which increase insulin secretion, and we have sulfonylureas, meglinotides or glinides, and incretin mimetics. We have insulin sensitizers that make insulin more effective. But like I said, these are not insulin. This is not insulin injections. They work on these insulin receptors, some of them, but they're not insulin, okay? So insulin sensitizers make insulin more effective. So that includes biguanide or metformin, the most commonly asked medication, and thiazolindazole. I don't know how to say that, but let's just put the thigh ones, okay? That one is also an insulin sensitizer. We have ones that reduce carbohydrate absorption, and these are called our alpha glucosidase inhibitors. We also, another way of saying it is our Archibos. These essentially reduce the sugar levels by reducing the small intestine's ability to absorb sugars. So that delays the body's ability to take in that sugar, which helps keep the blood sugar lower. And last ones we have is they increase glucose excretion, or they help you get rid of it. And these are, let's just call them SGLT2 inhibitors or sodium glucose transporter 2 inhibitors. And an example is canagliflozin. I don't know how to say that, but they all end in this gliflozin ending, all of these SGLT2 inhibitors. Okay. So those are all oral anti-diabetic agents that we use in type 2 diabetes. So sulfonylureas are those insulin secretagons, which means they increase insulin secretion. And they work in those beta cells to do that. So we have first generation and second generation. First generations we don't really use anymore, but they all end in amide. So the first generation sulfonylureas include chlorpramide, tolozamide or tolbutamide. Those are all examples of sulfonylureas, first gen. Second generation is the ones that we see more, which is the ones I would say for your exams to focus on, which include glimepiride, glipizide, and glyburide. They all start with G and all end in ide, if that helps you remember this class of drugs. So they all start in G and they all end in ide. And you want to take these in the morning because, like I said, you take this medication, it's one of the medications that you take, and then 30 minutes later, you have your food. Why? Because there's always the risk of hypoglycemia, especially with this class. So looking at the sulfonylureas, I always emphasize using a medication template because I think it organizes the drug classes much more easier. But this is just a summary of the class. That's what a fancy way of showing it like this. This is what it means. So as I said, we use this in type 2 diabetes, but they must also have diet and exercise changes. The goal is to decrease sugar levels. This causes hypoglycemia. And pretty much a lot of these drugs may or may not cause GI distress. So that might be another adverse effect to keep in mind that can potentially be caused from these anti-diabetic oral agents, okay? So these increase the number of insulin receptors or increase those beta cells. So that means we have more insulin secretion and that allows us to lower those sugar levels. But we don't give these in pregnancy. Rule of thumb is that most medications are contraindicated in pregnancy, except insulin. So you're going to see, and pretty much every contraindication is going to be pregnancy, renal or hepatic impairment, because everything in your body is metabolized by the liver and excreted by the kidney. So if you have problems with that, you're not going to be able to get rid of these medications. And as I mentioned, all of these drugs, you could also say as a rule of thumb, no beta blockers. Why? Because they mask signs and symptoms of hypoglycemia. So if these drugs as an adverse effect can cause hypoglycemia, that's going to be pretty scary if they're taking a drug that may block those symptoms. And we don't know if they're going into a hypoglycemic crisis, which means they could pass out and potentially die. It could be lethal. And you can give these sulfonylureas like I said, glypuride or glimepiride or glipizide with other oral anti-diabetic medications. You could give them together. That's okay. And that's pretty much all I have to say with those. I would say the key point to remember is that these drugs start with G, end in ide, that they can cause that hypoglycemia, GI distress, and the contraindications that I mentioned. Next, we have the glinides, or also called the metaglinides. And the good thing about this class is they all end in glinide. So repaglinide is an example. So glinides end in glinides. They're also insulin secreticons. They do the same thing. They stimulate insulin secretion. They lower postprandial glucose levels, just like the other class of medications did, which means that we give this medication and they need to have food present within that 30-minute time span. So they take it and then they eat. Not right away, but they must eat within 30 minutes of giving that medication. So something that we might see is that an adverse effect is hypoglycemia. So we need to watch out for that. And we can't give these with sulfonylureas. Well, think about it. Because if those drugs like glypiride, those ones cause hypoglycemia, and we're going to give them a medication like a glinide that's also going to cause hypoglycemia, that could be really, really bad. So you take this medication and you need to eat right after so that the sugar levels don't drop too low, but you don't want to take it with sulfonylureas because the sugar might get too low, okay? And these all end in glinides. Those are the things that I would remember for this class. Then we have thiazide. I don't know how to say that, but I'm just going to call these the thigh drugs, okay? So these are insulin sensitizers, which means they make insulin more effective. They make the body more sensitive to insulin. So if you're making the body more sensitive to something, they're more likely to react with it and use it. And it's going to make the body produce more insulin. We use these, and again, in our type 2 diabetes patients to lower sugar levels. All of these class of drugs, these thigh class of drugs, end in glitazone. That's why I said the G's can get a little confusing because there's a lot of G's, but glitazones are these insulin sensitizers, okay? But the problem with the glitazone ending drugs like pioglitazone is that it is cardiotoxic. I would remember that. It's cardiotoxic. But these don't cause hypoglycemia, which is really good because that means when you give this medication, it can help lower, or keep control of the sugar levels, but it will not lower the sugar level so much that an adverse effect can be hypoglycemia. So I would know for this class of drugs that end in glitazone, these glitazone drugs are cardiotoxic, but they don't cause hypoglycemia. And just something for tip, you could also give these with other oral anti-diabetic agents like metformin or sulfonylureas and even insulin. Um, Metformin is the most popular anti-diabetic oral agent, and it's part of the big I class, which is also an insulin sensitizer. Basically, makes your body more sensitive, which decreases that insulin resistance, which means, hey, our body can use insulin more, okay? Um, so this drug in particular, metformin, you can give this to patients who are 10 and older. It can also be used for things like polycystic ovarian syndrome, appetite suppression, and it can even lower that bad cholesterol, that LDL. But the main point of giving this drug is for treating diabetes. So it lowers sugar by decreasing that insulin resistance. Now, metformin causes hypoglycemia, okay? So even though this is an insulin sensitizer like the glitazone class that we talked about before, the glitazones don't cause hypoglycemia, but these do, okay? So these can cause hypoglycemia if they're taken with other secretagogues, like if they're taken with sulfonylureas, okay? So if they're taken with sulfonylureas and things, they will cause hypoglycemia. But if they're not taken with these other sulfonylureas, like the glipizide, those ones, it won't cause hypoglycemia. So you can remember with insulin sensitizers for the class in general that it normally will not cause low sugar levels, which is great, right? Because they won't go into a hypoglycemic crisis. But metformin can go into a hypoglycemic crisis if it's given with sulfonylureas, which is different than the glitazone class. And this drug can also have a metabolic taste, like a weird, nasty taste. Problems is that we don't want to give this if they have renal dysfunction. And the reason this is because if you watch my endocrine lecture, that is great. I mentioned this already. But the thing with metformin is that let's just say you're going to a procedure and you're getting IV contrast, something like you're going for a scan of some sort. You must stop this medication 24 to 48 hours before a procedure with IV contrast. Why? Because the contrast can build up in the body and it can cause renal dysfunction. So it's not toxic to the kidneys per se by itself, but in situations where you're getting an IV contrast for a procedure, it can cause toxicity to the kidneys. So that's another thing. And if they have a myocardial infarction or a history of that, we're going to want to switch to insulin. And like I said, the metformin and arcabose, or that alpha glucosidase inhibitor, those ones, they must be taken with food the same time you take that medication. But all the other ones, you take it within like 30 minutes of taking that medication. But all of these other classes of drugs, like I said, you take them within 30 minutes after giving the medication, but metformin and arcabose, you must give it with food present. Now we're talking about arcabose. So as I said, you take this one with food at the same time, not within 30 minutes. The way this one works is these alpha glucosidase inhibitors, or arcabose, they inhibit enzymes that break down sugars like maltase, amylase, sucrase. They inhibit those enzymes that break down sugar. So it delays the body's ability to absorb sugar, which means that our blood sugar isn't going to really go up. Now, it doesn't affect those insulin receptors in any way like the other drugs did. This one actually more works in the GI. So if this is working in our GI system, a very, very predominant adverse effect is GI distress. Okay, so I would say, right, it works. Usually I say for a rule of thumb, wherever it works, it also causes the same adverse effect. So this works in the GI area, which means an adverse effect is GI distress. So like flatulence or gas or diarrhea or abdominal cramps, these are all characteristic symptoms of arcabose. If we are giving a medication that is causing GI distress, we don't want them we don't want this medication to be given to someone who has a malabsorption problem or a problem with already absorbing sugars or a problem with their GI tract. That's not going to be so good for these patients because now we're giving them a medication and these people have GI issues. This medication is not going to work so effectively. These also, very important, do not cause hypoglycemia. They don't cause low sugar levels. So those insulin sensitizers, the biguanides and the ones that end in glitazone, don't cause hypoglycemia. Archibose doesn't cause hypoglycemia. Those are really important because the exams could ask you, which they have on mine, which ones or which classes of drugs cause hypoglycemia or have the adverse effect of hypoglycemia, or which one doesn't. And they could list like the sulfonylureas and different, medications there. And you have to figure out which one doesn't have the adverse effect of hypoglycemia. So that's where it becomes really important to know the difference. Okay. So even if you make like a little chart to yourself on which ones cause hypoglycemia and which ones don't, you're at a really good pace. And as I said, with Archibose, because it causes GI distress, and any rule with pretty much drugs that cause GI distress, they usually want you to take food with them. So with these, you're going to take food with it at the same time, just like metformin. But all the other ones, you take within 30 minutes of taking that medication. So the next class of drugs that we have that are anti-diabetic agents, we have something called dipeptidyl peptidase IV inhibitor, which I mentioned before, these incretin hormones, and incretin hormones are a form of insulin, but they're not insulin. So they help delay that breakdown of incretin hormones, which actually helps increase insulin synthesis or making of insulin. So these also reduce sugar levels postprandial or after you eat. So you take this and then you take food within 30 minutes. All of these drugs or this class of drugs, they all end in gliptin. So sitagliptin is an example. They're all going to end in this gliptin ending. Now, really important adverse effects. Once again, these cause hypoglycemia. They can cause nausea and abdominal pain, and they can cause nasopharyngitis or like similar to an upper respiratory tract infection, like runny nose, cough, things like that. We don't want to take any drug that ends in this gliptin ending if we're taking an incretin analog, because like I said, they work similar to insulin and it could further make the patient's blood sugar drop so low and make that hypoglycemic crisis even worse. And if they're fasting, we want to tell a patient to take a snack before bed to reduce really high morning sugar. Because sometimes what happens is that you give them this and it might drop too low, or you don't take anything and the sugar levels might just get out of whack. So we want them just to have a little something, because when you're fasting, your body undergoes stress. So that means their sugar levels are going to increase. So if you actually take a snack, it actually helps lower it. And like I said, all these drugs end in gliptin, but I would pretty much know that I must take this, like I said, within like 30 minutes of the food, and they cause hypoglycemia, and they can cause symptoms that are similar to like an upper respiratory infection. The last class that we have for these oral anti-diabetic agents are these SGLT2 inhibitors or sodium glucose transporter 2 inhibitors. So basically, they inhibit the transporter's ability in the kidneys, because the kidneys are what allows the glucose to be excreted in the urine. So what they do is that when we inhibit that SGLT2, we're allowing more of it to be excreted, because normally it's going to try to make a balance and keep some of that sugar. But if we inhibit that, we're actually allowing the sugar to leave the body and be excreted in the urine by the kidneys, which would also tell me if the kidneys are a major playing factor in this class of drugs, I wouldn't want to give these to someone who has renal impairment, right? Because they need the kidneys to do what they do, which is secreting the sugar in the urine. So we increase glucose excretion. That's what this class of drugs does. They all end in gliflozin. Just, yeah, that one. They all end in that same ending, and they're all given just for type 2 diabetes. I would know that for this class of drugs, they mainly cause like infections like UTI, yeast infections, itching in the genital area. Those are the things that I would know. So they are prone to causing infections with these. Because remember, sugar loves bacteria. So if you're peeing out a lot of sugar, that means your urethra or your urinal, the way your body is leaving with the urine, there's going to be a lot of sugar than there normally is there, which means bacteria like sugar. It's drawn to that. So there's always a possibility that these patients might be at risk for infections. Any questions about any of the oral anti-diabetic agents that I went over? No. Okay. So there's a couple other ones. We have injectable anti-diabetic drugs like amylin agonists, like Simlin or pramlintide. I'm terrible at saying things. I apologize for that. But basically, these these drugs mimic amylin, which is a hormone that helps slow gastric emptying, and amylin actually decreases your appetite. So we give these as an injection, a subcutaneous injection, 45 degrees, right, in those different locations that we spoke about. They decrease appetite, which actually helps lowering the sugar, because if you have less an appetite, you're not eating as much, and it's going to help with lowering those sugar levels. But things that it can cause is nausea, vomiting, anorexia, and headache. Remember, this is a GI working drug, so I expect GI-like adverse effects. Incretin mimetics, these are very similar to insulin, okay? These all end in glutide pretty much, with the exception of exotide. They end in glutide. I would just recognize these. And semaglutide is really important because it's also called Ozempic, and a lot of people take Ozempic for weight loss. And these are another form of medications that are given for only type 2 diabetes. Both of these are only for type 2, and they decrease the appetite and body weight, which helps with, lowering those sugars and helping with that type 2 diabetes. Once again, they also work more or less in that GI, so we expect nausea, vomiting, diarrhea, and weight loss because a part of it is helping you lose weight. And with Ozempic, you give it at the same time. It's once a week, and it helps maintain those normal hemoglobin A1C levels that I was talking about before, and it prevents spikes in glucose. Now, there's different herbs and things to watch out for. I would watch out for honey. I would watch out for something called ginkgo biloba. I don't know how to say it, but it's a commonly asked herb that you see a lot, and it can affect your sugar levels and the insulin's ability to control those sugar levels. The last thing, one of the most important things, because hyper versus hypoglycemia is the most deadly of them all. So hypoglycemia is when we have a blood sugar less than 40, okay? And there's two different ways that we can give this. We can give glucagon IM or IV. We can also give dextrose 50% IV or diazoxide IV. So another way that we can do this is we can also give a carbohydrate snack, like a soda, not diet, regular soda, milk, juice, like 4 to 6 ounces, something like that, or like 8 to 10 pieces of candy if they're conscious. But a lot of the times they become unconscious and they might pass out. So we have to either give them glucagon IM, an intramuscular injection, 90 degrees, or IV, okay? Now, the manifestations or the problems that you might get when you give one of these drugs is they can become diaphoretic or tachycardic or anxious as a result of the hypoglycemic crisis, but also just trying to elevate the sugar. They might go into all of these symptoms. But That's why it's important to know what are the signs and symptoms of hypoglycemia, because if you're thinking that's what they're in, I need to check their blood sugar level because I might have to give them glucagon, especially if they're unconscious. So glucose elevating agents, hypoglycemia, we got to watch out for GI upset and vascular effects. We want to watch out for thiazide diuretics when we give a hypoglycemic agent because it can cause hyperglycemia and then we could have another issue. And allergy, pregnancy, lactation, no. I already talked about the difference between DKA and HHS. Just remember that diabetic ketoacidosis is in type 1 and hyperosmolar hyperglycemic state, or HHS, is in type 2. And it doesn't have ketones or cruise-mall respirations or fruity breath like DKA does. Now, this is just a summary of all the important points that you need to do. And this is, I think, one of the most important parts because this is your nursing considerations or your nursing teaching. So before giving drugs that alter sugar levels, these are the things that you want to do. A thorough history, right? Are they an asthmatic? Are they taking those steroids? Are they taking beta blockers, right? Is that going to affect their body's ability to manage or see their signs and symptoms of hypoglycemia? Are their sugar levels going to be elevated because they're taking steroids, right? All of these things, especially if they're taking insulin. We want to look at their vital signs. That might tell us if they're in a hyper or hypoglycemic crisis. Their blood sugar levels and their A1C, which we do every 3 months, that indicates long-term compliance, right? Assess their ability to consume food. In other words, right, if they are having difficulty swallowing or they're unconscious, we know that we can't give them certain medications or even a hypoglycemic agent like a carbohydrate snack or a drink if they can't do that. We want to assess for nausea and vomiting because a common sign and symptom of when blood sugar is like in the 300 or 400 range, they could have nausea and vomiting. And we already talked about the different anti-diabetic drugs that can cause hypoglycemia. So if I were you, I would make a chart on which classes of medications cause hypoglycemia and which ones don't. If a patient is NPO for a test or procedure, consult a primary care provider to clarify orders for their anti-diabetic drug therapy, especially those type 1s, because they need insulin. They cannot go without it. So even though NPO, especially type 2 diabetes, they might say, okay, it's fine to not take their metformin, but type 2, like I said, insulin is usually an injectable. But once again, diabetes patients, we always just have to make sure that they're able to take whatever medications they're being prescribed. Keep in mind, right, that when a patient's under stress or they have an infection or they have an illness, they're at risk for a hyperglycemic crisis, and we do not stop insulin even if they're sick or something. When mixing up those insulins, we take the regular first, then the NPH. 3 times a day, glucose monitoring is recommended for our diabetic patients. Make sure that if they're having a surgery, they take their surgery in the morning so that they don't have prolonged fasting, which is not really good. Okay, we want them to have the earliest possible surgeries. Once again, if they're taking Aspart or Lispro or glucine, they need to have food there. The glitazones might cause liver problems, and metformin, we have to be careful with liver or renal impairment. We must always rotate the injection sites when you give insulin because they can get something called lipodystrophy, which is like little deposits of fat. So if they did it in their left arm today, tomorrow or later, they do it in their right arm or do it in their stomach or do it in their thigh, but change it every single time. Insulin should always be stored in the refrigerator. Make sure you do your rites of medication and make sure you're getting a unit syringe, not a milliliter syringe that will kill the patient. You should roll the vials in your hands. Most medications, like I said, those oral ones, you usually give 30 minutes before meals, but metformin and Archibos must be given with food because of GI upset. If they're in a hypoglycemic crisis, we can give them honey, fruit juice, a non-diet soft drink like soda, graham crackers. If they're unconscious, we can give dextrose 50% in water, IV, glucagon, IV, or IM. And is there any questions?